What we see is that the American healthcare system has really had four eras in its history. We start in the pre-industrial era of the 1700s through the mid 1800s, where really consumers had control over healthcare delivery and healthcare demand. And what we see after that era is we come into the post-industrial era. The modernization of our society in the United States occurred. We see also the professionalization of the healthcare industry. That's followed by an era of corporatization or corporate dominance, beginning in the mid 20th century through today. And then in the late part of the 20th century, the 1990s through today, we also see we've entered into an era of healthcare reform. So we're going to go over these four areas specifically, talking about how the U.S. healthcare system has evolved over time. In the 17 and 1800s, what we saw is that the medical profession was really not a profession at all, but in fact a trade. There were very primitive medical procedures used, the use of leeches and bleeding and purgatives to remove certain spirits or humors from the body. It was a very primitive way of thinking about healthcare. It was not evidence-based. It was basically you tried something, it worked, you tried on another patient and another patient, and it basically became something that people did. There weren't institutions that existed for the purpose of providing healthcare. The poor, when they were sick, they went to pest houses or almshouses. Otherwise, healthcare was provided in the home. This was the era of the house call, where medical professionals would come to your home and provide treatments to you in your home. There were dispensaries where various medical treatments and balms and other things could be dispensed, which was the precursor to the modern day pharmacy. And we also saw that there were mental asylums or institutions where the mentally ill would be housed for their entire lives. And so these were the places where some healthcare was being delivered, but there weren't broad or well-organized healthcare institutions in this period of time. It was difficult to assess when people were going to get sick, what diseases were going to emerge. There were a large number of infectious diseases at this time, things like cholera, typhoid, and others. And so basically, individual patients, the consumers of healthcare, relied on themselves. They self-diagnosed, they self-treated until they became too ill. And so there wasn't a predictable sort of use of any kind of health care. It just depended on environmental conditions and when people got sick and when people called for the doctor. There wasn't a very standardized or well-established system of medical education at this time either. Basically, to become a physician, you had to find an already practicing physician who was willing to apprentice you. And you followed him, primarily him in these days, around, and he showed you the methods and the procedures that he used for diagnosing and treating various conditions. Even if you were able to afford and to go to college, there wasn't a strong scientific evidence base for the reasons that people treated certain things in the way that they did. And so even if you were a medically trained doctor who went to Harvard or Penn or any of the universities that existed at that time, it still was not a very sound scientific education. In the post-industrial era, from the late 1800s to the mid-1900s, what we saw was a tremendous amount of modernization of society more broadly. And at the same time that new technologies were being developed, urbanization was taking place. People were moving into cities to have industrial and manufacturing jobs. What you saw was also a consolidation and a professionalization of American medical practice. A lot of the things that were happening at this time in terms of changes in society overall were mirrored in terms of how the healthcare profession was changing as well. There were lots of reforms, lots of changes. Just as people were moving to cities and living in large housing complexes and living in much closer community, so did physicians come together to create the modern hospital in this era. What we also saw is that there were groundbreaking medical discoveries during this time and significant advances in the scientific knowledge that medical professionals had. We had developments in anesthesia. We developed antiseptic technique, which reduced the amount of infections that happened after surgeries. We understood sterilization. All of these new technologies And all the way through 1929, with the discovery of penicillin, we were able to better diagnose and treat things in a way that had never been possible before. So the post-industrial era was really an era of significant medical growth and advancement. And at that same time, what the medical profession saw is that there was a body of knowledge for physicians to have, that there was something that should be done and shouldn't done in various cases. And what we saw is through that, there was a significant amount of professionalization. In this same period of time, the American Medical Association was created to create a guild that would identify physicians who were properly trained and physicians who weren't, right? And so all of these things were happening all at the same time to really create a much more sophisticated healthcare system. One of the things that was really unique in the U.S. healthcare system was the development of medical specialties. We have a large number of specialists in the United States, more specialists than generalists, actually. And so, unlike what happened in other countries, the medicine in the United States didn't focus around primary care, around the basic needs of the patient, but instead all of these new medical technologies allowed people to specialize. And so training in the United States primarily focused around various medical specialties and not on the basics of the healthcare. What we also saw in the same period of time is the development of public health, of the tools and skills necessary to keep large populations healthy. We began to see significant advances in infection control, stopping the spread of diseases like cholera and typhoid and TB. And so at the same time where you have this significant professionalization of the medical field, you also have significant advances in the field of public health. However, these two worlds were kept very separate. What was done in terms of trying to keep people healthy and keep streams clean so that they wouldn't spread disease, or keep rotting food away from people so that they couldn't eat it, all of those things were being done in the public health world and not done and by public health professionals and not being done by physicians. And so there created this divide between what was being done to create a healthy environment and to prevent infectious disease and what private practice physicians did in terms of just treating individual patients with the maladies that they came in with. What we see in the beginning of the 19th century is that after World War I, there was a tremendous need for people returning from war to receive health care, to not just treat their injuries, but to treat their ongoing health problems. And so the federal government at this time created the Department of Veterans Affairs with a division for health, primarily contracting with existing hospitals as well as other healthcare providers to provide care to veterans. A little bit before this, right before the World War, we see a significant effort to develop workers' compensation. And this is sort of one of the first health insurance, national health insurance efforts that moved forward in 1914. It was really used as a political test to see if government-sponsored health insurance would be possible in the United States. So they created a program where work-related injuries and illnesses would be the responsibilities of employers, that they would be required to carry insurance such that when their employees got hurt, that they would have access to health care for those industries. But unfortunately, what happened was not really what people expected. At the same time, there was a big push for private health insurance that actually prevented a national health insurance scheme from coming in place. What we see here is that, in fact, there were three major forces that push this need for some kind of insurance coverage. One is the advancement in technology. These new technological advances, such as x-rays, such as access to medicines like penicillin, were very expensive. The average American could not afford to utilize these treatments. So there needed to be some way of creating a system of financing the access to these kinds of medical technologies. In addition, what we saw is that people really wanted to get health care. There was a huge amount of consumer demand, and so people wanted to have cures for these illnesses that didn't have treatments in the past. And so there was a big social push to utilize and access the healthcare system. There also was a big economic reason, which was there was a significant amount of unpredictability about when people would get sick or what the cost of treatment were. There were no standardization. There was no Center for Medicare and Medicaid Services in the early 1900s that would set what the costs for various medical procedures would be. So, of course, there was price gouging. There were significant variations in terms of what things cost. And so the idea was is that health insurance would create a mechanism to ensure that people could get the treatments they want at a reasonable cost and begin to also control and rein in some of the billing practices of providers in the United States. What we saw was that there was sort of a push from the business side, from the private side, to develop health insurance schemes, and there was a real resistance against government health insurance schemes in the early 1900s. There were blanket health insurance policies that began to be sold for life or illness or accidents as early as 1911. States tried to create their own employer mandates where companies in those states would be required to buy and provide health insurance for their employees, but most of those initiatives failed. The first successful attempt at what we call sort of a modern day health insurance plan actually happened in Texas at Baylor University Hospital. It was a prepaid plan. It became a model for Blue Cross. Everybody who had access to that plan had to pay into that plan, but then they would be guaranteed access to healthcare services when they needed them. About a decade later, as we were about to enter World War II, the California Medical Association started a health insurance plan to cover the services that were being provided by California Medical Association physicians. So this was a move on the part of a doctors' union to ensure that there would be a way for physicians to get paid for their services. You have to remember, in this period of time, whether or not a physician would get paid for treatment was really very much an open question. Whether someone had access to the funds to pay you was unclear. A lot of times, even bartering for goods and services was done still in this era, where physicians were maybe being given gifts or other things to cover the costs of their care. As we see the modernization of healthcare as we enter into the mid-20th century, that was no longer a viable, sustainable option. So even health insurance options were being explored by physician organizations to ensure that doctors would get paid. We see a move post-World War II away from individual insurance policies and plans to having health insurance become employer-based. And that was in large part as a result of the fact in World War II, wages were frozen, there was a lot of resource scarcity, and so employers started offering health insurance to their employees as a benefit, much like we still do today, instead of being able to give them a higher wage. So they took on that expense as a way of keeping and retaining their employees. So in a time of real resource scarcity, employers did this out of necessity, and this was something that has obviously continued until this day. What we saw in 1948 in the Supreme Court is that they actually said that health insurance was an actual term or item of employment, a negotiable item in union management bargaining, and so it actually became further ingrained in the U.S. worker model that health insurance is a right to be negotiated for and something that would actually be a condition of employment, particularly for union employees. And what we see also is in 1954, there became even a greater incentives for employers to make contributions to health insurance. And what they did was actually made it an even larger benefit for the employee by making the taxable income that could be attributed to the employee for that benefit became tax exempt. So we see all these various incentives that came in place over time that really made employer-based health insurance a really attractive option for U.S. citizens. So what we see over time is sort of various periodic, episodic pushes for national health insurance. So we had the first push for workers' compensation in 1914. Ultimately, a very small system was put in place for workers' compensation, but as time went on, labor unions and other organizations began pushing a social agenda for the rights of workers and the rights for all citizens to be covered under a national health insurance plan. Franklin Roosevelt tried this in the 1930s when he proposed the New Deal. Ultimately, it failed. And in the 1940s, Franklin Roosevelt put forward a national health insurance bill, which also failed to pass. Harry Truman was the first U.S. president to propose his own national health insurance plan as a sitting U.S. president. And what we saw is that in the 1990s, both candidate Clinton and candidate Bush had made their own proposals for a way of curbing the cost of health care. So there's been these episodic pushes in the United States to achieve national health insurance. And ultimately, all of these actions that were taken failed. We were not able to achieve a national health insurance system, and there were many reasons for that. One was political inexpediency. It wasn't a politically viable topic to explore at the time when it was being proposed. There was always some political circumstance or barrier that existed to prevent having a national health insurance program. Ultimately, in 1914, when this was being proposed, the middle class and a lot of workers resisted it. There was big pushback even in the 1960s when Johnson was passing his Great Society, where initially a universal healthcare system was proposed, and we had to pull it back to only having Medicare and Medicaid. And there were also institutional challenges, right? The disparity of interest, the disparities between institutions and what their needs were meant that there were many different lobbies pulling in different directions. There were ideological differences, mandating, forcing that every citizen in the United States have to buy or use a health insurance policy was really contrary to a lot of political views. And so there were fundamental diversions, I would say, between the various political parties and between factions within those parties who were really fundamentally opposed to having a national health insurance system. On the other hand, there were definitely social groups, labor unions, social justice advocates who really said that access to health care, which means access to better health, is a fundamental human right. What we saw was a significant resistance to any kind of increased taxation, particularly amongst the middle class and also amongst business owners, for having to pay for this national health insurance system, having to pay more taxes to the government and having more governmental control over the healthcare system was something that many people felt very strongly about. That shouldn't happen. The most significant healthcare system reform in the United States prior to the Affordable Care Act was the creation of Medicare and Medicaid by President Lyndon Johnson in the 1960s. He was able, through an initiative called Johnson's Great Society, to actually push forward and actually put in place the systems that still exist today, the Medicare and the Medicaid programs. What was really the case back then is that there only was an option to purchase private insurance. But as people got older and they stopped working, they didn't have the funds or a way to access private insurance. Remember, most private insurance was primarily employment-based. So when people stopped being employed, there was no access to health insurance. Also, for people who weren't employed, which would be the poor and the chronically ill, they did not have a way to get health insurance. And so what had to be done was to create a system to protect these two vulnerable populations and to really take care of those who were underserved by our society. At this point, only the working middle class had private insurance. And so mainly the poor and the elderly were left to charity. And so that was not a viable system. And so they made amendments to the Social Security Act of 1965, which included creating the Medicare and Medicaid system. So what we see here is we have Title 18 and Title 19 of the Social Security Act, which govern Medicare and Medicaid. Medicare has now multiple parts. At the beginning, it only had Parts A and Part B. Now it has a Part C and a Part D as well. But what we see is Part A covered hospital care and nursing home coverage. And so that was designed to allow older people to be hospitalized and not have to worry about having access to health care. Part B covered participating physicians' bills, and it was a way of creating cost sharing on the part of patients and consumers. Medicaid is Title 19 of the Social Security Act. This program created a set of matching funds to the states that decided to create Medicaid programs that would provide care for the poor and indigent and chronically ill who were not over the age of 65. There was a means test that was developed by each state. There was a standard to determine whether or not a person was poor enough or made little enough money or was sick enough to be eligible for Medicaid services in that state. So Medicare is a universal federal program. All people in the United States over the age of 65 have access to purchase insurance through the Medicare system. Medicaid is state-based. Each state chooses to set up how they see fit a Medicaid program, and the federal government provides matching funds to support that program. Each state has its own standards for what it means to be eligible, what level of what we call FPL, or federal poverty level, is allowed to count to have you be eligible for Medicaid benefits. And it includes not just the elderly poor, but all poor people who are working and even some people with other chronic diseases. So that was the most significant change we saw in the healthcare system throughout the medical history. It really created a public government-based program that allowed for people to have access to health insurance even if they didn't work. What we saw in the HMO Act of 1973 was the first move to try to control medical expenditures. This act was put forward by President Richard Nixon, who was a very close friend with the founder of the Kaiser Permanente managed healthcare system. And so federal funds were made available to create funds and programs like Kaiser Permanente to expand these sort of prepaid medical plans where you would pay a premium and then you would have access to doctors and to hospitals that participate with that plan. And so ultimately, there was some initial support for this as a way of sort of reining in healthcare expenditures and to have federal grants to fund the HMOs. But ultimately, there was not a way to really get employers to participate in HMOs, and so it was a failed experiment. After we leave sort of the mid-19th century, we move into the corporate era of healthcare. I would really argue from about the mid-1970s through today. What we see in this corporate era is really the proliferation of healthcare and the healthcare industry as a business. It becomes a much more financially savvy, much more competitive industry for services, both inpatient as well as outpatient. New technologies as well as the globalization of healthcare really made the industry even more competitive. And so what we see is really a need for the healthcare industry to adopt and integrate the business practices that are used in other industries into the healthcare field. Up until this point, healthcare had primarily just been characterized as a service industry. It was not something that was seen as being a highly corporate business type profession. But now, starting in the mid-1970s, it really begins to change. We also begin in this era to realize that as large corporations begin buying up hospitals, integrating them, bringing them together, buying up multiple larger and larger and larger hospital systems until now we have the HCAs and the Tenets of the world. What we see is that as there is increasing consolidation and power on the part of corporations, they have a significant amount of influence on healthcare delivery and on healthcare finance. What we also see is health insurance companies also consolidating their power. And what we see is a reduced amount of power amongst consumers or patients. And so there's a big change in sort of the power balance that we see as we move into the corporate era. And we see that this consolidation and integration and alliances that are being done now continue to this day. There also, in this era, was a huge information revolution. We have the development of electronic medical records. We have the development of the internet. We have new technologies like telemedicine and telehealth. Healthcare has always been, in the United States, a very local, very geographically limited kind of business. But now telemedicine and telehealth and e-health have created ways to have caregiving, to have medical services provided across the country and around the world. So it means that we've improved access in rural areas and made the transfer of information that much easier, which has resulted in a somewhat of a resurgence in the empowerment of healthcare consumers. What we see in the corporate era is also this push to globalize. We see people traveling from country to country for medical tourism. We see people from the United States going to places like India or Singapore or Japan to get medical procedures done. There's been a huge boom in medical tourism in a number of countries around the world. Even in Western European countries, there's a significant amount of medical tourism from Americans who want to go there to get access to medical treatments that we don't have here in the United States. There's also a significant migration of health professionals. We have health professionals from all around the world coming to the United States for training as well as to work. As well as health professionals being able to migrate from the United States to other parts of the world as well. There's a significant amount of demand for healthcare products and services throughout the developed and the developing world, which really makes an unprecedented opportunity for healthcare expansion. And now we enter the last era that we see in the U.S. healthcare system, which is the era of healthcare reform. I would say this really began in the early to mid 90s, probably starting in 1992 with the presidential campaign of President Clinton and George Bush. What we saw during the era of President Clinton's presidency was a big effort to have a national health insurance program, which was advanced by the First Lady, Hillary Clinton. Ultimately, that push failed, and we did not get a national health insurance plan. But what we did get during his presidency was the Children's Health Insurance Program, which was an expansion of Medicaid. So poor children whose parents didn't work and who had and did not have access to health insurance could be covered and could be provided basic health insurance services under the CHIP program, which has existed until this day. Because many parents could not afford to buy or get access to health insurance, and maybe they didn't meet that means test. Maybe they made just a little bit too much money to be eligible for Medicare themselves. So for those children who fell in the gap, they made the Children's Health Insurance Program so that at least all children would have a chance to have health insurance while they're growing up, even if their parents were not insured. We also saw a big change during President George W. Bush administration, which was the Medicare Prescription Drug Improvement and Modernization Act of 2003, which added Part D to the Medicare program, which created a way for seniors to buy prescription drugs through the Medicare program at a significantly lower cost. Up until then, prescription drugs for people who were participating in Medicare were not covered in large part, which meant that there were significant out-of-pocket costs for prescriptions. And of course, people as they age, oftentimes they develop multiple conditions and have huge healthcare expenditures related to pharmaceuticals. And so the Medicare Part D program created a system by which the first amount of your annual healthcare pharmaceutical expenditures would be covered. There would be sort of a gap in the middle where you would have to pay out of pocket, and then anything above a certain amount you would then have covered by Medicare again. So it meant that basically you had some financial responsibility, but not nearly as much financial exposure had been the case before Part D was put in place. What we saw in this time is sort of as these reforms are taking place, we now have, if you think about all the way back, we now have people over the age of 65 are covered, not just for hospital care or end-of-life care or under a health insurance plan, but also for pharmaceutical coverage. We have children who are covered, regardless of whether their parents are. We have poor people who are unable to work or are working but don't meet the federal poverty threshold. So now we have the young, we have the poor, we have the elderly, we have them covered. The group that isn't covered, that's missing here, is the group that we were talking about in class, that group that is working but can't afford the health insurance premiums to buy on the insurance market, and maybe have jobs where they don't have access to health insurance coverage. So there's still this significant group that doesn't have access to health insurance and therefore has limited access to health care. During the late 1980s and through the 90s and the early 2000s, states, again, because remember, states have a lot of control over their Medicaid programs and over how they design their healthcare systems, states started to take matters into their own hands. So Oregon tried this by expanding their Medicaid program. The existing insurance pool was expanded to include people who had pre-existing conditions, and there was an employer requirement to provide health insurance to all employees, right? In large part, this was a successful experiment. There were some problems with it. And then we saw in 2006 that Massachusetts tried the same thing. There was an individual mandate in this case for every person who lived in the state of Massachusetts to buy a health insurance plan, with a few exceptions. Employers were required to provide health insurance plans for their employees, and there were subsidies that were provided to low-income people. As you're reading through this description, you might think, gosh, that sounds a lot like the Affordable Care Act. There's an individual mandate, there's an employer mandate, and there are subsidies provided to people who can't afford their premiums. And you're right. The Massachusetts Health Plan really was part of the model for what we came to have in the Affordable Care Act, and we'll talk more about that in a few weeks. There also was an insurance hub or clearinghouse where people could go to research and to buy their health insurance plans if they didn't have it through their employer, very similar to the health insurance exchanges that we now have in the United States. The Affordable Care Act was passed in 2010, a few years after the Massachusetts experiment. It was a very partisan piece of legislation. No Republicans voted in favor of it. The president obviously was very much in support of it, so much so that now the Affordable Care Act has actually been dubbed Obamacare. This is arguably his most notable, memorable political achievement during his presidency. There were a lot of compromises, a lot of lobbying, a lot of backroom deals were being made, and so there were a lot of compromises in this bill. Not a lot of things made it through unscathed, so it was very, very compromised in terms of a lot of the provisions, which we'll talk about in a week or so. It has been challenged repeatedly, multiple times in the courts, including 3 times in the Supreme Court. Ultimately, the Supreme Court has upheld the constitutionality of the Affordable Care Act multiple times. And in particular, the individual mandate piece, which requires everybody to buy health insurance in the United States. Ultimately, the federal government does have the power to ask individuals to buy health insurance, but they can't force individual states to cover more people, more poor people under the Medicaid programs. And so there's still this difference in terms of who's covered and how are people covered, depending on what state you live in. If you live in the state of Connecticut, the Medicaid program was significantly expanded. If you live in a place like Texas, the Medicaid program is very limited and only helps people who are extremely, extremely poor. Whereas in Connecticut, people who maybe have 1 or 2 full-time jobs may still be eligible for Medicaid because the federal poverty level percentage that is used is much higher in the state of Connecticut. And we'll talk about that more when we talk about the Affordable Care Act in detail. Obviously, the Affordable Care Act is still in effect. A lot of the implementation of the law has been delayed over time, but the major provisions have been implemented, such as implementing health insurance exchanges, the implementation of healthcare.gov, the expansion of the Medicaid programs in about half of U.S. states. But there are still major challenges that continue, and whether or not it will continue into the next presidential administration remains unclear. So what you've seen here in this lecture is a tremendous amount of change in the U.S. healthcare system in the last 200 to 250 years. And what we've really seen is a sophisticated evolution of U.S. healthcare, moving from it being not even a profession to being a highly professionalized, highly controlled, highly science and evidence-based medical profession. And what we've also seen is the role of consumers has changed dramatically over time. There's been eras where consumers had a considerable amount of control and eras where there were less. And now we're into an era where we see a tremendous amount of reform and change taking place, as well as a significant level of corporatization, which is part of the reason why many of you, I think, are interested in a career in healthcare, business, and administration. So I hope this has given you a broad introduction to the U.S. healthcare system and how it has changed over the years, and I'll look forward to discussing this more with you in class and online.